Hey, Mike, you there?
Oh, I'm here.
Where are you? You in Atlanta?
I'm in Atlanta Airport, trying to find a dark corner, of which there are none.
So we've got about 30 minutes. I know you've got pretty disgusting teeth. And and so we were talking recently about this P. gingivalis article, right? I think
you're I kind of take issue with the disgusting teeth thing. I think my teeth are pearly white. At least I got on mine, Matt.
But still a scary article, right?
Freaked me out. I mean, like coming from my standpoint, I'm already worried about Alzheimer's, and I think we've already released that podcast on Alzheimer's and the RECODE protocol. But this whole idea that P. gingivalis is being found in the brains of patients with Alzheimer's, it sort of freaks me out. And I think it made everyone a lot more aware about this whole mouth brain connection. We talk about the gut brain connection a lot, but I think that the gut needs to be from the in hole to the out hole. So we need to think about the entire portion of the gut. So unfortunately, though, I think that's about the limit of where my medical knowledge begins and ends. Yeah. So luckily, we've got somebody on the podcast today that I think knows a little bit more about the topic. Is that right?
Yeah, and we know that it's been implicated in cardiovascular disease, chronic inflammation, dementia, stroke, all these things. And you and I have kind of read the story, but we really wanted to get a true expert on who could talk to us about this connection and really what to do about it. So Dr. Tom Larkin is here. Tom, thank you so much for being here with us.
Good morning.
Good morning. It's great to have you. We have so many questions.
Hey there, I'm Mike.
And I'm Matt.
And I'm Jody. The Wild Health Podcast is our quest into human performance, longevity, and personalized medicine. Together, along with experts in these fields, we'll learn how to live longer, better, and become smarter and stronger. We'll do the deep dive into the research and hard work of putting it all together, and you reap the benefits.
Dr. Larkin, you're a busy guy. I think you've ran your own practice. You manage several practices. You've taught at universities. You teach these prevention courses and oral wellness courses all around. We really appreciate you being here with us. What really got us excited when I first talked to you is on your website, you talk about relationship-based dentistry, which sounds really cool, not transactional, because that's honestly exactly what we're trying to practice with our patients, this personalized relationship-based medicine. And you're doing it from a dentistry standpoint. What does that mean, relationship-based dentistry?
Yeah, great question. This is kind of a healthcare observation in general, everything that's happening in healthcare. There's kind of a demarcation that's happening between people that are focusing on patient-centered practice, and I use the term relationship-based versus transaction. The biggest qualifier there, the two things are that in the relationship-based, quality is a constant and time is a variable. Okay, that you take the amount of time to get to know the patient and to do a thorough diagnosis and workup. And so the work that I've been focused on for the past 6 years is the medical dental thing. And I don't know if any of you saw the recent Netflix movie Root Cause, and it's very, very controversial. In fact, I saw on social media yesterday, I don't know if this is true, that it was removed from Netflix because there was just so much bad information on there. But the underlying theme was that physicians and dentists need to work together. And so the journey that I'm on right now is to helping define that relationship and taking some things from my background and really, really training up the dentist so that we can speak the language, and then educating the physicians. What is the connection, the oral systemic connection, that in your work, in your functional medicine world, what do you need to understand? So
you spend as much time as you need with the patient and really focus on what they need. And it sounds like a very different practice than what I've been to in the past.
Yeah. For sure.
Yeah. I had a patient a couple of days ago. Our appointment was an hour and a half, and I felt like we hadn't gotten through everything we needed to. And it just is scary to think about how little time patients usually get with their dentist and their physician.
No, for sure. It's a whole different mindset.
It seems like the buzzword phrase is oral health prevention. Can you explain a little bit about what that means? I mean, we get that we all should brush and floss,
right?
But I'm sure there's more to it than that.
Yeah, there really is, and I will describe dentistry's shortcoming because it's kind of historic, and basically prevention is not popular. It never has been. There's always been a struggle. In my lectures, I always talk about the first person to bring prevention to dentistry was Charles Mayo, 1915, when he's establishing the Mayo Clinic. He was pleading with the dentist, that to help him. And basically they were, too focused on other things. And he really understood that the mouth was affecting the outcome of the patients that they were seeing even 100 years ago.
So one quick question, kind of off the top. I heard Jody the other day tell his kid that if he didn't floss, he was going to die. Is that too harsh? Like, if
I hated to be the one to break the news, and I told him that I hate to be the one to tell you this, but if you don't floss, you're going to die.
And when you say prevention, is it mainly just brushing and flossing, or what other things?
Not at all. So here's the paradigm shift. This is what brought me in, and I'll make this as brief as possible. But in the late 80s, I'm in practice, and I'm having patients with gum infections, and I'm doing what I was taught in school, which is send them to the specialist who treats gum infection. And the standard of care back then was surgical removal of infected tissue. Okay, it's going to be hard for you guys to get your arms around this because it was pretty barbaric. And so I set out on a journey that led me to a very controversial, at the time, practitioner he was 30 years at NIH. His name was Dr. Paul Kais. Invented quote unquote Kais therapy. And he said, this is a simple infection, and you treat infections with anti-infective things like antimicrobials, antibiotics. And he just showed that it was a very easy thing to treat. So where we at today is kind of a mix at dentists understanding that you use anti-infective. For instance, you in medicine, you have a standard for wound care. In dentistry, we do not. Okay, so if you're in the ER and somebody comes in with a wound, you know exactly what to do, a protocol. We have an infection in the mouth, and our protocols are all over the place. And so I took a couple of years to kind of create the operations manual for how to treat infections and inflammation in the mouth.
So how do you treat it? I mean, I'm a little worried when we talk about anti-infective things, when we talk about systemic antibiotics, because we know what that can do to the gut microbiome.
Absolutely. Great question, because I've never been comfortable with antibiotics. And even Dr. Kais, he introduced antibiotics. And so what I found is this is a simple infection that can be 90% of the time plus can be controlled with proper rinses that don't have the effect. Because we didn't have any knowledge of gut health, 20 years ago, and that's front and center now. So there is a company that makes an antibiotic, a formulated rinse and spit, but I can talk about, some of the things. I brought a couple products that in the past month. And then another area of focus for me personally and the dentist that I'm coaching is laser therapy, because I consider lasers almost like holistic, and lasers are awesome. I've got a conference coming up here about laser therapy.
Now, are lasers going to be effective against the biofilms? Because I know that's one concern, specifically with P. gingivalis, is that it creates these biofilms that are hard to get to with local therapy, correct?
Right. So that's why they're a nice solution, because with rinses and you're just using something that's on the surface, and P. gingivalis specifically is invasive. It not only adheres, but it's also invasive. And the various laser therapies have depth. They have depth of penetration, and they're very efficient on the pathogens, the periodontal pathogens.
So just to clarify, so you're talking about these infections in the mouth using a local, you're talking about rinses, but is it a local antibiotic you're using? What is it exactly, and what's the difference, and what are you doing with the laser? The laser's not to treat the infection, right?
Yeah, so it's a combination. So let's step back a little bit and look at the microbiology of the mouth, and let's go back to diagnosis before we talk about treatment. So one of the things that Dr. Kais brought to dentistry was the use of the phase contrast microscope, looking at wet samples chairside. I tested every patient, and part of my protocol now is I'm teaching dentists how to do this. I mean, I've got several practices here in Lexington that are doing it. I helped design a microscope that was it's updated. It's got, Wi-Fi capability, and you can do it with an iPad. It's really, really cool. The technological breakthrough is the biofilm DNA. So there's 3 companies, there's 3 labs now, one in Canada, one in Germany, one in the US, that actually we can look for the pathogens. So of the 600 to 700 types of bacteria in the mouth, there's only about 10 or 12 that are really considered pathogens. Okay, so these are anaerobic. They have to live under the gum without oxygen. Okay, so we're looking at specifically, if we're targeting those bacteria, it's pretty straightforward. So when you say brushing and flossing, here is the number one issue. Everything that we've done in the past and that we continue to teach people to do is not antimicrobial. So if you brush with something, you basically are just pushing these bacteria around. Okay. And so what Dr. Kai says is that everything you do needs to be anti-infective. Every mouth rinse needs to kill bacteria. And what happens is when the pathogens, you have a balance in the mouth, you're not sterilizing the mouth. You need homeostasis between the microbiome in the mouth. And what happens is when the pathogens kind of get to a certain level above bacterial load, then the environment in the mouth changes. Okay. So, proper rinsing and it's a great question on the flossing. The second you said that. So I just did a podcast last week with a dentist and the big confession was, I don't floss. And I said to him, you know what? I don't either. And we went on this whole thing about, in detail of, I brought the samples of and there's new research that shows that, first off, people don't do it. 90% of people don't do it. Right. So you're on this, what's the definition of insanity? We keep telling people over and over again to do something. And so Dr. Kai's talking, and this is the updated version of what he used a rubber tip with baking soda. And so these are the interdental stimulators. And that was research that shows this is how you treat gum disease.
So the kind of probing that you get at the dentist office, inner gum, because I can see this little thing you're holding up, but everybody else can't. So instead of flossing, you're saying people should do what?
So interdental stimulation. So these are called soft picks. And so basically, because you can floss.
So if you just Googled right now while you're listening, gum, GUM soft picks, you can see what we're talking about exactly.
Right. So the whole theory.
I've used those things. I really like them. Yeah. They seem to work really well.
Yeah. And so you put a medicament on there, or you put baking soda. So, and I have I'm going to give you copies of my book on prevention. This is my consumer book where I show people very simply. Now, for a physician, I would use this for a diagnosis in the office. If you want to make just a very, very gross diagnosis with a patient, I would just take that and put on some gloves and just come, not in the front, but kind of to the side and just probe one area. And probably 50% of your patients would bleed on that stimulation.
I'm doing it to myself right now. So not a very difficult diagnostic test.
Right. No, that's it. And that's exactly where I would do it. Just go back right here and go in and out several times. And I'm telling you will find patients that bleed profusely.
There's blood everywhere. It's all over my computer.
Ruin the microphone.
Luckily, no blood, so I'm good. But that's a really easy diagnosis.
Super easy. So 50% of your patients are going to bleed. So what does that tell you? Hey, you've got breach of epithelium. Now you have oral systemic. If you've got pathogens under the gum, they have a direct communication. Okay.
And so how we treat that? So was it antibiotics with these rinses, or what are these rinses?
No. So basically, okay. So what I teach is what it's called risk classification. I make things really simple. That was one of my hallmarks when I was teaching the dentist at the university is I make things super simple. I don't try to impress people on how smart I am by getting down in the weeds. Okay. So risk classification, in my practice, the dental hygienists see the patient first. So when I come in, I would like to know, are we low, medium, high risk? Okay. There's 2 bacterial infections in dentistry. That's it. Gum disease, decay. Decay is a bacterial infection. Patients don't understand that. We've done a horrible job of explaining in this model when you talk about relationship-based versus restorative, reactive. So the way that we train dentists even today is this whole reactive model where we react to disease and we teach them how, you've got a hole in your tooth, you're on a radiograph, there's an area of decay. And this is a bacterial infection. We need to be telling patients, you can do things to prevent this, okay? Anti-infective measures. So I'm talking about how I come through the diagnosis. Now we have the biofilm DNA, and this comes very much into your functional medicine model. So what are some of the things that you're going to need from me or someone that I've trained when you're working up a patient? Well, now we need to look at pathogen specific, okay, and look at the biofilm and what levels are they present and at what levels, okay? There's some controversy is, can you eliminate them completely? So when you get your test back, there's going to be a bacterial load level for, above threshold or below, because there might be some trace elements. But here's the important thing. We talked about P. gingivalis in Alzheimer's disease. I just compiled this research. I've got one that came in this week, PG and pancreatic cancer. Okay. So we had a patient came through our website last week, and I get copies on all the website leads, because we probably have one of the few websites that talks about this connection. And this patient said in the email, I was diagnosed with pancreatic cancer and I understand I might need to do something different. Okay. So what's the first thing that we're going to do when she comes to the dentist? It's going to be the biofilm DNA, because I want to know what that level is.
So when you say you're going to do the biofilm DNA, you're going to take a scraping, you're going to look under the microscope, you're going to identify what bacteria are there, whether they're pathogenic or good ones.
So the microscope, you can't diagnose, the pathogens, right? It's more, you're more looking at the environment. It's kind of a gross evaluation, and then the test has to be sent to the lab. Now, one of the things that's coming, hopefully within the next 12 months, and I had mentioned to you offline, point of care testing. And I've got an individual that's coming to speak at my laser conference, just a brilliant medical device person that you're going to meet, Dr. John Carreno, that has a point of care device. And just by chance, I mean, he really is focused on PG as one of the tests that you're going to be able to do. A physician could do it, because it's going to be a swab test, and you put it into a little deal that docks with an iPhone. I've seen it. It's, it's pretty cool. Now that's going to be a paradigm shift, because then you're actually making the chairside recognition of specifically PG. PG is being implicated just across the board, not only in this study. And Dr. Carreno looked at this study, and I jump to the conclusion when I look at these things, I don't know how to really get into the weeds.
So you're talking about a study that shows an association between periodontal disease and pancreatic cancer. So so the study we mentioned at the very beginning of the podcast was about P. gingivalis and how its toxic proteases show up in the brains of Alzheimer's patients, which sounds scary, but at the same time, we kind of went off the rails a little bit with amyloid beta, thinking that may be a cause, but it's not. It's just kind of residue of the disease. So, So talk to me about if there's a causation link there, how much that's been proven, how much of it is just speculation, and if we can actually do something about that.
Yeah. So Dr. Carreno, we were talking about this study in particular, and like I said, he can interpret, this kind of data.
The pancreatic cancer study?
Yeah, the pancreatic cancer and Alzheimer's. And he just said straight up, he said, that's causal. It has causal all over it. And he said, the people that I know that are looking at that, that was a really, really powerful study. So, and there's been one causal study on cardiovascular disease and periodontal pathogens. So there's like hundreds and hundreds of association. But, me, the common sense guy, says, hey, I've got this gum infection, and now there's periodontal bacteria showing up in a pancreatic tumor. Common sense says that shouldn't be there. Okay. And my really common sense says, I don't want that bacteria in my mouth. Okay. As a preventive measure, if I had a choice between having pathogens in my mouth and not, okay. So let's create a simple system to not have them.
Gotcha. So, I mean, I'm always a pretty big skeptic, and just people and health and medicine is pretty complicated. So, so it seems like when I hear you say that a true expert in the field is saying he really thinks it's causal, looking at the data, that makes me think I probably need to pay attention and be serious about it as well. But are there any studies showing that we actually can reduce risk, or is it just too early for that? Like reducing risk by getting this cleaned up? No.
So let me get into the cardiovascular part, because I've spent a lot of time on that prevention. And
I think there's a little more evidence for that right now.
Oh, for sure.
But to me, they're so linked. They're inflammation based, metabolism based, that, I feel like if you were to show me that it definitely makes a difference in cardiovascular risk, I'm probably going to assume, at least until proven otherwise, that it makes a difference in Alzheimer's as well.
Yeah. So the person that kind of put me on this track was in 2013. I saw Dr. Brad Bale. He's the author of The Heart Attack Gene. He was the one that kind of lit this whole thing up for me, because with my background in prevention and then seeing the oral systemic connection, it wasn't that clear to me. And then my eyes just kind of got wide open. So what I was able to see there is that, and like I said, the number of articles that were with association are substantial. Okay, so what is that particular link? Okay, so basically, so he created a methodology, and he backed into this, meaning he didn't set out to prove a hypothesis. So he's focusing on arterial health, what he calls arteriology, and he says, if I can get your arteries healthy, I can give you a guarantee of prevention from these various things.
Heart attack, stroke,
any inflammatory based things. So the protocol he created relied a lot on tests. The Cleveland Heart Lab has inflammation biomarkers, the blood test for biomarkers. So here's what happens.
Things like HSCRP and other inflammatory.
Myeloperoxidase, and there's about a half a dozen things that they look at on the inflammatory side. So here's how he backed into this. So he has a patient with an elevated biomarker, and just anecdotally, in the course of trying to work this patient up, he sends him to the dentist, and then the dentist finds out, oh, you've got an infected tooth, and they pull the tooth, and those markers just boom, like right away. Okay. And he goes, well, that's interesting, right? So maybe I should be sending people with elevated biomarkers to the dentist. And then it just was like over and over and over again. So then he just, so that's how this whole dental thing, so it was very results oriented. This wasn't random. He was seeing lab tests change dramatically after dental evaluation and dental treatment. So that's how that got started.
Gotcha. And and it makes sense, the connection to me, but are there any actual studies showing reduction of cardiovascular risk when you've cleaned up the mouth?
Oh yeah, for sure. And so one of the parameters that they use is the CIMT, the carotid ultrasound, where you're not looking at, this is different than the traditional ultrasound in that you're not looking at lumen, you're not looking at flow, you're looking at the health of the intima layer in the carotid. And there are several studies that show patients under periodontal maintenance. So that's a term that means that's someone that gets their teeth cleaned 4 times a year, actually have a reduction in inflammation and a change in the soft plaque that's associated there. So that's really central to the model. I know some of that is caused by statins, some of that transformation of the plaque, but taking away the oral inflammation. And so that's a very distinct study where you're measuring arterial health based on the dental maintenance.
And we'll put in the show notes those studies so you can kind of read those for yourselves and go through and just kind of make your own decision about how strong that evidence is. And it just makes sense. And I think we should be doing this. When I'm seeing a patient, I feel like I could identify severe periodontal disease pretty easy. I can put the pick in their mouth as well, see if they're bleeding. But my understanding is that a lot of the population, maybe up to half, can kind of have mild or moderate periodontitis and are kind of at risk from that. We've also looked at some oral microbiome testing platforms. So I kind of 2 questions there. Okay. Should we really be identifying these patients with mild or moderate disease? Did that play a big part in their stroke and cardiovascular risk? And then I guess the second follow-up question is, what do you think about these oral microbiome testing platforms?
So here are let me just back up 1 second and talk about what are the oral drivers of inflammation? Okay. So it's periodontal disease. Okay. Any infection of the gums, which is most easily diagnosed with bleeding. Then the biofilm DNA identifying the pathogens. Okay. The second driver is endodontic disease. Now that was kind of what this movie was trying to get at, which they did a horrible job by saying 98% of cancers are caused by root canals. They just got off on all these crazy tangents, but there is some truth to the fact that infection associated with the roots of the teeth. So this is an infection in a different place. Okay. It's not in the gum. It's at the base of the tooth. And that has to be diagnosed most accurately with the CBCT scanner. That can't be done with just a digital radiograph. So most dentists do not have that. Okay. So that's the second component, is the CBCT scan to look at, because you're looking in 3 dimensions, and some of these little areas of infection, they are substantial, and they're sitting right next to vessels like the mandibular canal, and they can seed that. Okay. The third area, and this is a really, really growing area of dentistry, is sleep apnea. Okay. That drives inflammation. And so that diagnosis, that screening can be very much a part of what the dentist needs to bring you, because those are the drivers. So if you are measuring inflammatory, one of them is a nitrous oxide one that really correlates very strongly with sleep, one of the inflammatory biomarkers. So that's very much within the wheelhouse of the dentist. So if you send to the dentist to get that clearance, you can say, here's where they're at with the pathogens. We did the CBCT scan. I don't see any lesions of any kind that I'm concerned about. And we did a sleep screening, and this is where they are there. Those are the three things that you'd want from me.
Gotcha. So the severe patients, obviously I'm going to send those. Patients that are maybe at risk for cardiovascular and stroke, even if their mouth looks okay to me, I'm still worried about inflammation. Yeah. I'm going to send those to you. Is there anybody that really doesn't need to go through these protocols? I mean, young, healthy patients not at risk, or should really I be sending everybody for screening?
Well, here's the thing. And once a dentist incorporates the microscope in the practice, this is what they find. And it's really a big moment for me when I show a young dentist this. They will do a screening on somebody in their 20s. They have no pockets. They have no areas of destruction. Their biofilm is like crazy at risk. Pathogens, spirochetes, banks of white blood cells. And so what I'm doing is I'm catching them before the damage, maybe 5 to 10 years before they have visible damage. So what I'm saying is our traditional method of diagnosis in dentistry is based on a rearview mirror. The damage has already occurred. Mm-hmm. Okay. So if you don't approach this from a microbiological standpoint, you are not going to be doing true prevention.
Gotcha. Okay. So, I mean, that makes sense. Everybody has a dentist. Everyone goes to dentists. So if I can send my patients to a dentist that gets this and can actually prevent this, right, I'm all for that. The big question though that I have too is cost. I mean, I hate talking about cost and things like that, but is insurance going to pay for these tests that you're doing, or is that going to be out of pocket expenses? Because every patient I have, they're dedicated to their health, but they're having to make tough decisions on it because no one has unlimited resources.
Right.
So talk to me about the cost of some of these things.
And that's the beauty of the microscope, because even back 25 years ago, it's included in the exam. And I insist on that with my doctors because I don't want that to be a barrier of any kind, because not only from an educational standpoint, because the people, because we put the biofilm up on a big monitor. Okay. When they see it visually, it makes a giant impact, because what we're talking about, and you know this, because this is a day in and day out struggle. When you try to change people's behavior, it's a very complex. It's one thing to do the medical dental stuff, but influencing behavior is a whole nother thing. And so the visual is a component of that. I don't want that to be a barrier. So we use the term included in your exam today, and we include it in the exam. Okay. The cost of the biofilm DNA is about $150. That's out of pocket. Okay. And that was one of the opportunities I saw when that technology came up. And I said, dentists aren't going to understand this. They're going to start to present this, and the patient's going to say, does insurance cover that? And the dentist is going to say no, and the patient's not going to, you have to set the framework for this, right?
So if I send a patient, if as long as their insurance covers dental care, most of this is going to be covered. There may be a couple $100 of extra out of, okay. Yeah, no, that's great. I mean, for the bang for your buck, that seems like a pretty valuable thing in general.
Yeah.
So we're talking a lot about what we do once we're in the office, which a lot of times is either too little, too late, or I'm already in pain. What can I do at home? I know we 4 times a year for cleaning, and we've already kind of discussed, and that's great. And a lot of people do that already, but what can I do aside from these soft picks?
Right.
What else can I do at home?
Yeah. So the most important part, because there's nothing that I can do miraculously in the office if it's not followed up with home care. This is daily disruption of the biofilm. Okay. So when I talk about anti-infective measures, here's the key. It's with mouth rinses, antibacterial. And for the most part, this is not over-the-counter stuff. They just, a lot of those products are alcohol based. There's a lot of issues there. So technique wise, in addition to the interdental, irrigation, water pick, just massively important. I mean, that is a super effective. So any patient that we're going to diagnose, that's going to be a part of their therapy. And in addition to that, we may want them to be using an antimicrobial solution. To me, that's kind of that's the home care, is irrigating with something that's antimicrobial.
Gotcha.
So that's a whole different conversation of different products. I can tell you, I brought some samples of some stuff that I'm evaluating this month. One of them is it's a molecular iodine, because truthfully, betadine is a great antiseptic that's not practical to use in the mouth because of the mess and the stain and everything. And there's a new formulation now that can be put in a water pick that has all the benefits, because that's a tried and true antimicrobial, but that's an example of one. Sodium hypochlorite is probably one of the better, and I don't recommend this for patients, even though I may do it personally, is I put some bleach in the water pick, a couple teaspoons of bleach. And I'm telling you, it's super.
I just keep imagining someone using iodine in their mouth and an orange glowing.
Yeah, exactly. So that's why when someone sends me something, I use it first. I want to know everything about it. Put a capful in the water pick, and it seems like a nice solution. I want to know what it tastes like. I'm looking for things that are barriers. Okay, you can give me the best rinse in the world, and if it's awful tasting, I know people are not going to follow through.
Mm-hmm. Speaking of that, is there something that is kid oriented or?
Yeah, so there's a variety of products, and not to get into the whole fluoride thing. Some people are comfortable with fluoride. Right. There's a lot of natural products. I mean, baking soda is a fabulous. It's not only antimicrobial, but as far as like balancing pH, just straight baking soda, and that has never changed. Okay, I love anything that's baking soda based. Right.
What about fluoride? What do you think?
I'm just. I have to say that I'm just on the fence with fluoride, because I've seen both sides of it. I do know this, and I have a long-term perspective on this. It gets, when you get super focused on one thing that's too far out there, it can be a bit of a distraction. And so I let that be a personal choice.
Gotcha. Yeah. And it seems that's a whole podcast. So I don't want to go down the rabbit hole. I didn't know if you had a quick soundbite about it, but on the fence, that makes sense. Now, there's also a lot of kind of implant and root canal haters out there. What's your stance on this? I mean, is it implicated at all in chronic disease? What do you think?
Yeah. Great question again. So let's talk about implants, because that's the real driver now in the market. The technology has improved so much, and the techniques, and it's very impressive, the end result. But here's the deal. The people that are out on the circuit, so to speak, are saying, 99% success rate. We've really got this down. But what they don't understand is that they're taking patients with periodontal disease, never taking care of their teeth, remove all the teeth, put in these implants, and now they're getting what's called peri-implantitis. The pathogens are still there, and they can get infected. And that's kind of if there was kind of a dirty little secret that's out there, and there are periodontists, specialists that would tell you that the infection rate of dental implants is very high. So they need the exact same protocol. They need to be on rinses. They need to, laser therapy for infection, whatever. They are not the cure-all that is being presented. Okay. Mm-hmm. Now, root canals, same thing, misinformation, drama, over exaggeration. There are a certain percentage of root canals that fail. And when they fail, the problem with root canals, technically, so that the interior surface of the tooth is like a honeycomb. Okay. It's not a smooth surface. It's got all these little caverns in it. And so basically what happens is when you go into the center of a tooth, surgically remove the soft tissue, you leave a lot of tags behind, microscopic tags, right? But in accumulation, it's there, right? And so the whole theory behind the anti-root canals is that you're leaving dead tissue behind that can necrose and whatever. And so getting back to my approach, which is instead of alarming people or over-exaggerating, let's talk about what's new. And that laser conference that I'm having here at the end of April, there's a new technique with this erbium YAG laser, and it's called photoacoustic. It's like shock waves. And I mean, you just take this laser and you put it in the tooth, and in a matter of 10 or 15 seconds, it blows everything out. And it's a complete sterilization of a tooth. And this is new technology. So my focus, I want a message of hope. I'm not trying to scare people about stuff. Can we do a better root canal? I think there is a better technique. If I had to have one personally, I would want this laser root canal. So that's kind of my area of focus. But yes, there is a small percentage of root canals if left. And the problem there is that they're asymptomatic. Some of these granulomas they're asymptomatic. You don't know there's a problem. It doesn't hurt to bite. They're not sensitive, and they sit and they kind of fester. And that is problematic.
Mm-hmm. So the reason we wanted to talk to you, and I think we're going to have you back as well, but we've been talking for a while and I want people to digest this, but we wanted to talk to you because when I saw what you're doing and kind of read about it and kind of researched, I really wanted you kind of on our team treating our patients, because we take patient care as kind of a team approach. We need experts in each of these areas to really reduce risk for stroke, cardiovascular disease, and dementia. So we're going to be sending patients to you to help us with this. But there are a lot of people out there, there are a lot of other physicians that, like me, they're not an expert in oral care. There are probably dentists out there that want to learn more about this, and there are also patients out there that want to know, where can I find a dentist who understands this and is about prevention, not just treatment of disease.
Right.
Are there any resources, places where people could go to learn more about this and get hooked up with a good dentist, or just dig deeper in and make sure that this area of their life
or questions to ask their current dentist?
Yeah.
Maybe to see like if he passes muster.
Right. Yeah. And I'm happy. I'll leave you my email address. I'm happy to field any direct questions to your audience. That's a very difficult question. I mean, there's a formal association, the American Academy of Oral Systemic Health, and those are like-minded dentists, prevention. But once again, there might be people with different protocols there. So there's not a standard protocol, so to speak. And there might be like individuals like myself that are just trying to do something ground up. It would be nice. And that's why when I think what you're doing, my immediate attraction, I looked at your functional medicine model, because mine had been pretty much just the cardiovascular disease when I was starting up with Dr. Durham. And I was like, and then I saw your model, and I go, there it is. That's the ultimate model, right? So you do need a dental component plugged into that. But it's all inclusive. That's what functional medicine is.
But you can't treat everyone. We can't treat everyone. People that are in a different area.
Right.
Is there a great resource where they can find someone they can feel confident is going to be able to do this preventative care?
No, that's been the problem. That's been the problem all along. Even with the Bale-Donine method, is how do we connect dentists and physicians? And I want to go get this workup, but I have to go find a dentist. No, it's a problem to this day. Okay.
Gotcha.
There's not a.
Well, like Jody said, are there any specific questions if you had 3 minutes to figure out if a dentist gets it or not, what would you ask?
Yeah. If the dentist and the dental hygiene team, are they clued into this oral systemic connection? Do they do any bacterial tests? And then do they do the cone beam x-rays? Those are the main things that I would need to know that I was thoroughly evaluated.
Gotcha. So those would be kind of some code words. If the dentist does say that again, the cone beam.
The cone beam, the CBCT scan, instead of just like a regular X-ray, they do a cone beam, and there's a growing number. I mean, it's a very expensive technology. It's hard for the private practitioner to afford the deal, but more and more are starting to do it. And then, do you do any bacterial examinations?
And so I guess it's a problem if not a lot of dentists are doing this, but you're training dentists,
yes,
right? So I think you have a couple courses coming up in the next month or two.
Right.
Is there a website or anything for registration?
Yeah.
For those?
So my website is, one of my websites is POWhygiene.com. Proactive Oral Wellness is the acronym for that. And so there, I'm doing, this is, as you could tell from talking to me and looking at my stuff, this is a very daunting task. I mean, it's just like I'm one person trying to make a change, and I'm kind of doing stuff. I love Lexington, so I'm trying to do some training here locally. So I'm doing laser training for hygienists. I found a fabulous practitioner who I bring in to train that technology. And then this preventive intensive, which I want to bring to what you're doing, which is kind of the executive physical, my concept of what an executive physical looks like, with a focus on dentists and physicians. Because back when I was a younger person, back in the day, there was the Cooper Clinic in Texas. You went to Cooper Clinic to get worked up. Well, as we now know, the treadmill is not the standard of care,
right,
in a proper test. So that's another area of interest I have right now in helping to define.
So with that POW hygiene, dentists can actually sign up for the courses. Okay, perfect. So what we'll do then is this is really important. I'm really excited to be able to offer this to our patients. So we are going to be working with you, but in the show notes here, we're going to link to that website where any dentists can kind of go to get training in this. As well, we'll put your email in there. So if patients or someone wants to reach out, you've got a pretty big network across the U.S. of people who are doing this. So you can probably refer them to somebody.
Yeah.
Okay,
I can sure make an attempt.
And then I think we want to have you back on in the near future, but we just wanted to introduce this concept to people so people are thinking about this and as part of their prevention in general. They're making sure they're really addressing, we know it's inflammation. And so if there's a clear source in the mouth, we need to be not just talking about nutrition, not just talking about exercise and other things, but really addressing all the root causes, not just a couple. So, well, thank you so much for coming on. We'll have you back soon. And I can't wait. I think I'm going to try to come to your course as well, just so I can really get myself educated on this.
Absolutely. Enjoyed it.
Awesome. We hope you like listening to the podcast as much as we like making it. If you think it's valuable, share it with somebody. Send it to someone you think would really benefit and leave us a 5-star review in iTunes. Those reviews really, really help us out. Find us on Facebook and follow us on Instagram at WildHealthMD. If you didn't like, well, why are you still listening? Email us and let us know what we can do better. But the best way you can thank us for our time is to leave a review and share. Until next time.